Welcome to Vilnius, Lithuania.
Hello, everyone. Welcome back or welcome to the ESE live studio here in Vilnius. And I would like to introduce you today the speaker, very well-known person in our endo society or in dental society even, Professor Shanon Patel, who is going to be also one of the speakers during the ESE autumn meeting here in Vilnius late October. Hello, Shanon.
Hello.
Thank you very much for accepting this invitation to
Thank
be
you very
here.
much. Yeah.
And today will be talking a little bit about the topic you are going to deliver during the meeting.
Mm-hmm.
However, we will be talking a little bit from the clinical and practical aspects. Yeah. But before, I would like to introduce for those who don't know Shanon very well. So you, first of all, you are endodontist. You are clinician. Yeah. You are practicing 4 days in the clinical practice, so you know what the endodontics is about. And we hope to hear very nice points that you can actually practical points. But you're also a researcher, you are also a professor, and you are educator and teacher at King's College London.
King's College London,
King's College London.
The best dental school in Europe.
No doubts. So thanks again.
Thank you.
And I think we have to start a very interesting topic. So about the cracks and this topic have been discussed in endodontics for more than 50 years. Mm. We now have classification system, diagnostic protocols, and even ESE position statements. Yep. You was heavily involved in those. Yep. Yet in daily practice, cracked teeth still remain one of the biggest clinical challenges.
I agree.
Why do you think this problem is still so difficult to solve? And why do you think the topic is receiving so much attention today? Because it is.
Well, they're two quite complicated questions.
Let's start.
I think the reason we're getting... Sorry, what was the first question again?
Why do you think this problem is still so difficult?
I think, so you can tell this is live. There's more of a focus on cracked teeth, but we still don't have much guidance on how to manage cracked teeth. And what I've also noticed is most of my colleagues, when I talk to colleagues in London or anywhere, we're seeing more cracks in teeth compared to 10, 20 years ago. But there's a disparity between what we're seeing and what we were sort of advised or how we were told to manage these things when we were doing our dental training or, as specialists. And I think the cracks have increased in prevalence, and one of the main reasons is because patients are clenching their teeth more, they're more bruxers, they have more parafunctional habits compared to 5, 10, 15 years ago. When I first started doing endo, most of my patients were coming in, and it was the same practice I've been working in for the last 25 years. Most of them were secondary caries or primary caries, very, very few crack-related issues. Whereas now, when I look at my day doing an endos, it's mostly crack related. Fracture lines or diagnosing vertical root fractures that can't be managed. And we're seeing much more of this, and it's mostly, I think, to do with parafunctional habits. Yeah.
And probably therefore this topic is receiving so much attention, just because not
Yeah.
only you see these
Yeah.
problems,
We
but
all
also
are. But,
we all. Yeah.
but the issue is we're still, as a profession, not very confident about how to manage the cracks. That's a major issue, and what we're trying to do with the European Society of Endodontology, with this position statement that I was involved with some great co-authors, was to sort of demystify cracks and vertical root fractures and give some simple guidelines on how to manage them.
Okay.
Yeah.
So let's go through this. So diagnostic tests.
Yeah.
We use BI test,
Yeah.
transillumination,
Yeah.
selective anesthesia, CBCT.
Yeah.
If we are honest about the limitations in sensitivity and specificity,
Yeah.
how confident should we really be before making a definitive diagnosis of the cracked tooth
Yeah.
and starting treatment?
Okay, well, yeah, go on.
And what is your own diagnostic protocol? Maybe you
Okay,
can cover
yeah.
these and then give us advice.
Yeah, so my diagnosis starts the minute the patient walks into the surgery. I just look at the patient, and a lot of patients, you can tell that they're bruxers. They've got really hypertrophic masseters, and you know, they've got some pain in a tooth, and you think, well, I know why you probably got pain in your tooth. It won't be caries, it's going to be a crack-related issue. Sometimes you can, then, you know, you listen to the patient, listen to their history, and even before you assess them clinically, 90% of the time, you know, you formulated your diagnosis. I don't know what you think. You know, then you just confirm things by doing an examination and taking a scan. Normally with the intraoral examination, if a patient's got you know, you look with a microscope and you'll see fracture lines on the marginal ridges, especially distal margins of lower second molar teeth or upper or first molar teeth. You see crack lines typically. And sometimes patients can localize the tooth. You know, you can press it with your finger, just push firmly. Don't get the end of a mirror handle and whack it. And that's the worst thing you can do. Just use your finger first.
Yes.
And push on the tooth. Is it tender? If it isn't, then tap it gently with the end of a mirror handle. And then if the patient says, oh, I don't know which tooth it is, what I do is I give them the tooth sleuth. I don't use it myself. I give it to them. And I tell them to play with it until they can reproduce their symptoms. Again, that's where I do it. But, you know, you look at most of the textbooks and they'll have a picture of, you know, a dentist holding the tooth sleuth. That's crazy. You should get the patient to just play, and then they'll go, oh, it's just here. And then you tell them to hold it, and then you work out which tooth it is. I don't really use a lot of sensibility testing in practice. That's just my way of doing things. I just try and get the patient to reproduce their symptoms. And then, you know, take a scan, and then depending on the symptoms, you have to manage it. If it's irreversible pulpitis, the patient will need a root canal. If it's not, if it's sharp shooting pain lasting for a few seconds only, less than 5-10 seconds, I normally recommend restoration with a cuspal coverage restoration as soon as possible. Yeah.
We now have the ESE classification. Yes, grazed lines, incomplete fractures, cracked tooth, split tooth, vertical root fractures. And it is already widely used. In your opinion, is this classification truly useful clinically, or can it sometimes create a false sense of precision for that is really a dynamic process, so we can...
Well, I was involved in those classifications. Of course it's good. But no, you're right. But what we try to do is clarify the different categories. So, I mean, for example, a crazed line, a lot of dentists think, well, you know, we need to manage it. It's a crack, but it isn't. It's just a superficial break in the enamel. It's not pathological. It's just physiological. It's wear and tear. So no, I think the classification we've developed is actually very effective. And the feedback we've had, myself personally and by the European Society of Endodontology has been very good about the position statement, which you can also download as a PDF from the ESE website.
CBCT and CBCT limitations.
Yeah.
CBCT has transformed endodontic diagnosis.
Yeah.
But when it comes specifically to cracks,
Yeah.
the evidence suggests that we are often detecting the consequences, periapical changes,
Yeah.
furcation bone loss, periodontal defects,
Yeah.
rather than the crack itself. Yeah. Does this mean that we are sometimes diagnosing cracks too late, or are we becoming too dependent on imaging for what is still mainly a clinical diagnosis?
Yeah. Well, any imaging technique, whether it's radiographs or cone beam CT, is just part of your diagnosis process. It's like a jigsaw puzzle. It's one piece of the jigsaw puzzle. So you can't just rely on your scan as something definitive. Let's be really clear about this. The cracks we're seeing are very, very fine in width, maybe 50, 100 microns. So your scanner will not have the resolution to pick up these small cracks. What you're looking at is, what you're looking for are very subtle signs of periradicular bone loss, so crestal bone loss, or maybe if it's more advanced, like a root fracture, periradicular bone loss around a root. So it is a useful adjunct, but as I said earlier on, most of the time you can work out which tooth is cracked just from the patient's symptoms or eliciting their symptoms by getting them to reproduce them with tooth sleuth. Or if you don't have a tooth sleuth, just use a cotton roll, get them to bite on that. You don't have to use the tooth sleuth.
So let's go to the treatment of the pulps involved in these kind of teeth. So the evidence supporting vital pulp therapy, especially pulpotomy, in mature permanent teeth has grown considerably during this decade, let's say. If a cracked tooth presents with symptomatic pulpitis, but the crack appears confined above the cemento-enamel junction, is there still a biologically sound argument for choosing pulpotomy instead of immediate root canal treatment? And what about this, in general, your opinion and your experience in vital pulp therapy of cracked teeth or
I think
endo treatment?
You have to contextualize the cracked tooth, because you can't just look at the tooth in question. You've got to look at the bigger picture. Why has the patient got the cracked tooth? A lot of the time, as I mentioned earlier on, there are parafunctional issues. So the tooth is being worked on really, really hard. So I normally favor root canal treatment, primary endo. I won't do a pulpotomy on a case like that, because the pulp is a bit stressed and it needs a cuspal coverage restoration because there's a crack. So even if you do a pulpotomy on a slightly compromised pulp, the fact that you're going to do a cuspal coverage restoration, a crown maybe, or an onlay but with a deep margin adjacent to the crack, it's going to distress the pulp even more, and it's more likely to need endodontic intervention in the future if you do a pulpotomy initially. And the thing about working in private practice is you need to do something that's predictable for the patient. You can't afford to do something that may work or may not work. You need to do something that's going to be predictable and effective. And in my hands, with teeth with cracks in them, if they're irreversible pulpitis or borderline, root canal treatment is more predictable than a pulpotomy.
Okay.
Yeah.
Yes, and actually, even those follow-ups should be strictly followed. I think after this, if someone decides to do vital pulp therapy, because in general, in my practice, I see those people coming with non-vital pulps after some period of time. Yes. Okay. Much of what we currently do in managing cracked teeth, it's a cuspal coverage. Deciding when to monitor versus intervene, and even extraction thresholds, is still based largely on expert opinion, retrospective studies, and observational data. Are we making irreversible clinical decisions every day based on evidence that would struggle to meet modern standards?
God. Right. So there is some good emerging research coming out from America, actually. A group led by Professor Hilton. They've done some really good stuff on cracked teeth. Practice-based, they've got this big practice-based research network of hundreds of dentists, thousands of patients, and they followed up these cracked teeth. And I think if you see a cracked tooth, but it's asymptomatic, you can just review it on a periodic basis. Mm-hmm. However, if you have a symptomatic cracked tooth, then it needs some intervention. If it's definitely just reversible pulpitis, as a sharp shooting sensation that disappears, then I think, and the patient also has parafunctional habits, then I would recommend a cuspal coverage restoration. An onlay, but where the area of the crack is, just dip the margin further down. If the patient has irreversible pulpitis, then, or borderline reversible, irreversible, as I said before, I would recommend root canal treatment followed by provision of a cuspal coverage restoration. Mm-hmm. Yeah.
Okay. The timing of cuspal coverage remains controversial. Immediate, before operation, or after endodontic treatment. The argument for early cuspal protection is compelling, preserving dentine, slowing crack propagation, and possibly influencing pulpal outcomes. So why has this not yet become standard of care?
I think the profession is slowly realizing that whether it's a cracked tooth or a tooth that's needed an endo after, gross caries has been scooped out of the tooth, you need to restore it as soon as possible. You can't wait for signs of healing radiographically or patient symptoms settling down. If you're confident with your diagnosis, you're happy with your root canal treatment, then I recommend to patients to get the crown done as soon as possible. When I write back to the referring dentist, I give them a timeline. I say, I've advised this patient to have their crown done within 2 weeks. Because what happens otherwise is patients forget, and then they remember when the tooth fails catastrophically, and then of course it's the endodontist's fault. It's not the referring dentist's fault. So, and there is some research from America, which showed some, I can't remember the studies now. I think it was maybe Davis and Sharif. There's another study from a group in Thailand, and they showed that basically cracked teeth, if had a poorer prognosis after endodontic intervention, if they weren't restored in a timely manner with a cuspal coverage restoration. Mm-hmm. So you need a cuspal coverage restoration, but you need it as soon as possible.
In practical clinical terms, how important is deliberate cuspal reduction when managing cracked teeth?
Yeah, that's a good question. As endodontists, sometimes, of course not you and me, Laura, we're fixated with white stripes and teeth and lateral canals and whatever. You've got to take a step back. You've got to look at why the patient needs an endo. Okay, so they've cracked their tooth. Why have they cracked their tooth? Mm-hmm. So they talk to them about parafunctional habits to minimize parafunctional habits, but also look at their occlusion. Look at when they go into excursions. Have they got heavy working side contacts or non-working side contacts? You need to talk to a referring dentist about this and how they need to think about making the occlusion a bit more harmonious. You, as the dentist doing the root treatment, cut the cusps down. You should cut them down by a millimetre or two, well, not 2 millimeters, about a millimetre. So the tooth is out of occlusion once you've done the endo. So then so you're less likely for the tooth to fracture afterwards prior to the cuspal coverage restoration.
And now let's go for the patient communication and shared decision making, which is very important, I think, in such a certain information situation. Cracked teeth often sit in a diagnostic and prognostic gray zone. How do you personally explain that uncertainty to your patients without either over-treating or creating hesitation, fear around decision-making?
Yeah, so I think you just got to be very transparent and honest with your patient. So I'll tell the patient, what I think is going on. I'll show them photographs. So, I'll take photographs and I'll sit the patient up, show them the scan, show them a photograph of the tooth. And then I go through the options with them, like you would with any dental procedure. And ultimately, it's the patient's decision, but we can guide them. And normally, if they're not, it's normally black and white, they should try and save the tooth. But if they're not sure, because they've had a few implants, they're thinking, well, you know what, I'll just have the tooth out and have an implant. They sometimes say, well, what would you do if it was your tooth? And I said, well, if it was my tooth, or if it was my assistant's tooth, Naomi, who's like in her 30s, I would say, I'd try and save the tooth. Let's try and keep that tooth for as long as possible. Because if you put an implant in, no matter how well it's placed and restored, it's not bulletproof. There's a 1 in 20 chance that implant will fail within 5-10 years, especially if the patient's got occlusal issues, they're loading it, parafunction, it's got a higher failure rate. So nothing will last forever. So all you're trying to do is drag out the tooth for as long as possible.
Absolutely agree. Let's have a clinical situation. Let's say you are performing root canal treatment, the access cavity is open, and you identify a crack extending towards or into the chamber floor.
Yeah.
What is your exact decision-making process in that moment? Do you stop treatment, continue, or completely change the direction?
Yeah, that's a good question. So if I see a crack running along, typically, you're doing your endo and then you start preparing the root canals, and you can see the crack running into the canal entrance. So if it's within a few millimeters of the canal entrance, I'll carry on doing my endo. And don't forget, now the way we're doing endo is in a more minimally invasive way. So we're using narrow taper instruments, and I've moved over from warm vertical to doing single point endo. So I'm putting less stress on the tooth, and I'm fairly not quick. I'm efficient with my endo, so I'm not spending a couple of hours, or some people do endo with 2 or 3 visits. I do it all in one visit, so there's less insult on the dentine. And then I deliberately obturate apical to the crack. And then I obturate the affected part of the root canal with flowable composite. And that'll be incorporated as my core. And that seems to be a reliable way of managing these cracks. I was at a great presentation in Utah at the AE this year by Mr. Davis, who published a paper, Davis and Sharif, I think in 2019. He's done some really amazing work following his cracked teeth. I think a 90+% survival rate over 4 years. So it is predictable, it when done well. But these are sort of cracked teeth, so that, they're not complete fractures, they're incomplete.
Yeah. The red lines.
The red lines.
Every clinician has an internal threshold.
Okay.
A point where, regardless of restorability or on paper or patient's preferences, you know that the tooth is unlikely to survive for a long time. What finding or combination of findings crosses that line for you personally?
A lunatic patient.
Too much expectation.
High expectations. Patients very well with unrealistic expectations. If you've got, let's say it's the last standing molar tooth, so low right second molar tooth with a fracture line that looks like a straightforward crack line in the marginal ridge, but there's significant periodontal probing, let's say 8-9 millimeters, so it's running down to the apex of the tooth. Then in those sorts of cases, I'd be like, no, we can't do this. But if there's only maybe 3-4 millimeters of probing distally, and the patient's got a febrile occlusion, they don't have a history of being a hardcore parafunctional habits, then I would do the endo, but I would be telling the patient, look, this has got it hasn't got as good a prognosis as a tooth without a crack. Because again, when we start citing, success rates or survival rates, it's always based on sort of the ideal scenario. But these cases are compromised, so it's not the ideal scenario.
Yeah, I think you already covered a little bit this, but iatrogenic factors, bonded restoration, ceramic onlays, aligner therapies, aging dentitions, and the increasing occlusal load. Modern dentistry may in some way be contributing a growing cracked tooth problem that endodontists are ultimately left to manage. Yes. Do you think that cracked teeth are primarily a restorative problem, or are they fundamentally a biomechanical disease of the aging dentitions and the chronic occlusal fatigue?
Oh, that's a good question.
Has a modern restorative dentistry unintentionally accelerated cracked tooth epidemics?
I think it's a combination. It's longevity. Patients holding on to their teeth for much longer. They're much harder on their teeth, not just parafunction, but habits like chewing ice at the end of their drink. My 13-year-old daughter, she likes to chew ice. I'm like, you can't do that. I'm telling you. She doesn't understand it. Mm-hmm. And so we're much harder on our teeth. Yeah. And also there's this big emphasis on, biomimetic dentistry and stuff like that. But dentists need to understand the basics, the basic evaluation of patients, how to assess their occlusion. So many times you see patients who need an endo on a lower or upper first or second molar tooth, and then you look at their occlusion, they have no canine guidance, right? So if they had a canine guidance that was re-established, they'd be less likely to be cracking teeth. Yep. So we need to take a step back and understand and manage the basic aspects of modern dentistry before we start doing all this sort of more advanced, sexy dentistry.
Absolutely agree. Over the course of your career, has your philosophy regarding cracked teeth changed in a meaningful way?
Yeah.
And if so, what changed it?
I think experience, it has changed, and it's experience. So when I first qualified, so many decades ago, when you were still in dental school,
I was.
I think when you saw a crack running into a root canal, you'd stop down tools and tell the patient, look, this tooth's a goner, we're going to take it out. And I think even the AE guy, they have this cracked tooth, cracking the code position statement, even that mentions that, if the crack is going into the root canal, the tooth is toast, you should take it out. But actually, that's not the case. And so I've become, in the last 10, 15 years, when I see cracks running into the root canal, as long as they're maybe 3-4 millimeters, I'm still happy to obturate those teeth and advise the patient that this is going to be fine as long as it's carefully managed. And also the way we're
precisely follow that.
Yeah,
yes,
but
we cannot leave these things without follow-ups.
Yeah, so we're managing it differently. We're more gentle. So we're not, when I qualified, we'd be using Gates Gliddens down root canals and big tapers. But now we're not doing that. We're doing things in a very minimal way. 3-4% taper, relying a lot on our irrigation. And then with single point endo, so you're putting less pressure on the tooth, restoration straight away. So they are predictable, but as you said, patients need to be advised that you need to have the tooth monitored on a periodic basis. And also I do really emphasize parafunctional habits in my patients. I told them about clenching and even food habits. So, typically sourdough bread. I love sourdough bread. 2-3-day-old sourdough bread, the crust of it, really nice to chew on. But when you're chewing laterally like this, forcefully, you're going to flex the tooth. So you've got to be sensible with what you're doing. And we're all surviving much longer now. So, our longevity is increasing. So if we want our teeth's longevity to increase, we need to be a bit more gentle with them.
Mindful, yes.
Yeah, mindful, yeah.
Thank you very much. I would like to invite Monica Freire on the stage. Monica, you was following, as always, the chat and questions. Do we have any questions?
We do have some questions. And first of all, thank you so much, Laura, for leading again these preview live sessions. And thank you so much, Shanon, for accepting our invitation. We are delighted to have you here and also very excited to have you in Vilnius in October. So let me start with a very practical question for you. So one of our viewers is asking, well, I'm looking at buying a CBCT machine. what voxel size should I look for? Would the voxel size have any influence on diagnosing cracks?
Good question. No, the voxel size will not have an influence because these cracks are really, really small. So the resolution of the scanner isn't going to be good enough. Not everyone, a lot of people are fixated with voxel size for image quality, resolution on a scan, but it's multifaceted. It's not just the voxel size, it's the hardware, the detector, the positioning of the patient, your exposure parameters, and so on. So I wouldn't be too fixated with voxel size. If you are thinking about buying or starting to use a cone beam CT scanner, you're not. I wouldn't be suggesting using it to detect cracks in teeth. If you have a good enough scanner, it will pick up the subtle periradicular bone loss that is associated with cracks in teeth, but it will not detect cracks within the tooth unless it's a complete fracture, which you would see clinically. There are lots of software well, not lots. There are a few software programs that have been marketed that can detect fractures, or apparently can detect fractures in teeth. However, I think you'd be able to detect the fractures by just doing a good clinical examination and just assessing the patient properly. You don't need a scanner and export the DICOM data into the software package to detect cracks in teeth.
Lovely, thank you. Second question for you. Do you expect that future generations of CBCTs will be more reliable in detecting cracks, or has the technology reached a plateau?
I think I sort of answered that in the first question. However, I don't think we're going to be detecting cracks within teeth. We'll be able to see the subtle periradicular bone loss around teeth, like crestal bone loss on the distal aspect of a molar tooth that's suggestive of a cracked tooth. What I've seen, though, with the quality of imaging from scanners is it's the top scanners. So I use a Marita, you use a Marita, don't you? So for me personally, that's the reference standard that all the other manufacturers have aimed to be at. And what's happened with the image qualities, it's plateaued off. There hasn't been any significant improvement in the last 5-10 years. So I think, we're at that level where we're getting the most out of our scanners. Maybe they've got something around the corner. Maybe there's going to be some AI stuff coming out soon. But I think within my career, I'm just happy doing what I'm doing, really. Just working on first principles and listen to your patients. Just look at them, listen to them, and then assess them properly. And usually you can work out where the crack is. All the cone beam CT scanner does is help you a little bit, or make things a bit more, make you a bit more confident with the management or the tooth. But you normally work it out just the diagnosis just from your clinical examination when it's cracked teeth.
Lovely. Thank you, Laura. To wrap, I think that we are running out of time. Do you think we should close for today?
I think yes, and as always, you can rewatch our recorded interviews on the platforms, on the YouTube, on the Instagram, Facebook, and LinkedIn. And of course, you can also put some questions over there, your comments and so on. So I think we will be very glad to answer them afterwards, just engaging with the audience. And also Shanon will be the speaker for the autumn meeting here in Vilnius, as I said already before this interview. And our autumn meetings are very close, very cozy meetings where a lot of time, or let's say enough time, will be dedicated for answering those questions and for the discussions. So we have learned this in Krakow during the Krakow meeting that the discussions were so important. We received a lot of questions, a lot of discussions. So now we really arranged the program to have enough time to address all the questions and provide the answers if we are able to provide these answers. So please join us for Vilnius Autumn Meeting. Thank you, Shannon, very much.
My pleasure. Thank you very much
for being here. And one more thing for the postgraduate students or for the researchers or for those who are involved in the science, the deadline for the poster is approaching. So I think the deadline is on Monday. Yes?
It's the 25th.
25th.
So there are a couple of days still.
Yes, so please spend the last weekend.
Spend
Spend the weekend submitting an abstract.
And be on time with your submissions. Thank you very much.
Thank you very much.
For watching, and we are coming back with new interviews and with new very interesting topics.
So it's over to you now for the sports.
Thanks a lot.
Thank you.
See you.
Bye-bye.
Thank you so much. Have a great weekend.